Red Lano, Red Latinoamericana de Neurooncología.
So Adriana, thank you very much and the organizing committee for the very kind invitation to attend this Congress. And I think, as Adriana was saying, I applaud the organization of this multidisciplinary situation. The skull base was probably one of the first groups. Multidisciplinary now is very fashionable. Everybody is doing multidisciplinary, but we were one of the first groups to look at multidisciplinary approaches because we realized that the tumors at the skull base are very complex, and surgery alone, as we're finding out today, surgery is not the answer. It's rarely, for some benign tumors that we can remove totally, but in general, it's not the only answer, and we need adjuvant radiotherapists, medical oncologists, and pathologists to help deal with these very difficult tumors. So I applaud you for your efforts in this regard in neuro-oncology here. That's 16 minutes. I hope that's not 16 minutes, because I've talked for 4 minutes already. Anyways, I'm going to give two talks today. One is on the evolution of skull-base surgery from our open classical techniques to the more current minimally invasive endoscopic techniques. And my first talk, I'm just going to show you what we have done. There's going to be no data there. And in my second talk, I will present some data to show where I think the current limitations and indications are for these minimally invasive techniques. So let's start with this. So as you can see here, this is our results over the last 3 decades in terms of skull-base surgery. And we've had a large experience with the open approaches now for very complex skull-base tumors, almost 3,000 patients. And over the last decade, we've had increasing experience with endoscopic approaches, now almost 800 patients. Most of these, of course, are pituitary, CSF leaks, but as we'll show you, we've done now almost 200 cases of expanded approaches for complex tumors of the skull base. And as I mentioned there's many reasons for success in open skull-base surgery. Magnification, but the multidisciplinary team approach was really the key approach, including neurosurgery, my head and neck colleagues, plastic surgery, maxillofacial, radiation oncology, very important, medical oncology, as you see, pathologists. If you look at the evolution of open skull-base surgery over the years, it really has allowed us to deal with certain tumors that 3 decades ago were not surgically accessible. These were the area they called no man's land. The neurosurgeons would go down to the base but stop. The ENT maxillofacial would come up and stop. So these tumors were not really well dealt with. And we see that these approaches helped us improve survival. And this is for cancers of the interskull base over the last decades, showing definite improvement, of course, with adjuvant therapy in some of these cases. So the open approaches allowed us, with the introduction of new techniques, new approaches, to really approach all areas of the skull base. No longer was any area that we could not reach. And with this type of approach, we have a patient, a young man like this, in 1996, goes back, presenting with proptosis. The diagnosis, a biopsy, was an aggressive mesenchymal chondrosarcoma. The treatment, as you can see here, was the classical craniofacial resection, which is basically a craniotomy as well as a lateral rhinotomy, allowing us to get a total removal of this tumor with adjuvant radiation and chemotherapy. Here he is now 17 years later with disease-free. Likewise, this young man was 29 years of age, presented with diplopia. You can see he had a lesion involving the ethmoid sinus. That biopsy was a squamous cell carcinoma, very aggressive cancer, as you all know. And the prognosis for a squamous cell carcinoma back then was about 5%, 5-year survival, virtually a death sentence. Again, with our ability at that time with doing a craniofacial resection, in this case because involving the orbit, we had to exenterate the orbit. We had to repair that with a free flap, rectus free flap, so our plastic surgeons helped us that. But you can see this young man, 20 years later now, he has had no evidence of disease. So we cured this cancer. So there's many advantages of the open approaches as shown here. As well, however, some disadvantages. And what I want to make here for the neurosurgeons here and the younger neurosurgeons, that the open classical approaches are still very important and necessary in skull-base surgery. So if any neurosurgeon here wants to be a skull-base surgeon, he has to learn the classical open approaches because, as you'll see, they're still needed. However, we learned a number of lessons, and some of these hard lessons from open skull-base surgery. First of all, these were major operations. They remain major operations, and they carry significant complication and risks. And even in the current series of open skull-base surgery, the complication rates are still high, as you can see here. We also learned that despite our ability to get to everywhere in the skull base, there's certain things that allowed us not to do what we wanted to do. And so the issue is anatomy and biology. Sometimes anatomy and biology can trump very good, excellent surgery. And we know now that cavernous sinus surgery, at one time we would go into the cavernous sinus and try to remove. That is really not applicable. We don't operate in the cavernous sinus anymore. Glomus jugulare tumors with high rates of lower cranial nerve palsy, we do not operate on those because we know that radiation is a very effective, proven effective therapy, low postoperative morbidity, and most cost effective. So a number of lesions that we used to operate on, we no longer operate. We also learned that quality of life issues are very important in neurosurgery and all of medicine. And there has been over the last decade a paradigm shift in skull-base surgery where we have to look at the quality of life. We can go in and remove half the skull, but if the patient is left in a very poor condition, poor quality of life, that is not a good outcome. So, quo vadis, where are we going in skull-base surgery? Well, this takes us to the issue of change and innovation in surgical practice, but we know there's change and innovation in every specialty here, in radiation oncology, in medical oncology, and we now, and particularly surgery, is impacted by technology. We use this now in all of our surgical procedures, and then the whole issue of minimally invasive surgery. And neurosurgery was not the first to this, general surgery and other surgeries, but now we have this in neurosurgery. Of course, you're all familiar with neuroendoscopy and now endoscopic spinal surgery, and of course endoscopic pituitary surgery, which I believe is the state of the art now, and the standard, it will become the standard of practice of pituitary surgery. So what about endoscopic skull-base surgery? Why the endoscope in skull-base surgery? Well, we'll see there is some inadequacies with the existing approaches, and we want to, of course, reduce the high complication rates, and we hope that maybe these more minimally invasive can do that, and of course we want to improve patient outcome. But with any new technique in any field, we have to look to see that it's safe, reliable, and it's effective, because we all know that new does not equal better. So if we look at the evolution of endoscopic skull-base surgery, it's gone through the same stages at open skull-base surgery. And this is where we are now, basically, in looking at where the indication for these techniques may be and where the limitation. And while the early results in some of these pathologies I'll show you are promising, very promising, we have to keep in mind that we lack long-term follow-up. So this is an interesting patient. In fact, Dr. Bernstein will know this patient because he referred him to me, I think, Mark. 59-year-old patient with an epidermoid. He had, and we all know these are recurrent, he had 2 previous craniotomies. And then he was fine for a while, and then he presented with some visual disturbance, and he had developed, in the interim, a sellar lesion here, and a clival lesion that you see here. So what is the best approach in this? Well, our ability to do endoscopic pituitary clival for clivochoroidomas is very easy. So here's a lesion just anterior, and the question was, can we just remove the anterior part of the anterior skull base, the planum, to get at this lesion? So this is basically the approach that we would use here. This is a pure endoscopic approach, going through the nose using a binostril technique so we can deal with these like we do under the microscope. We are now taking the bone off the sella and the anterior skull base. This is it, we've removed it. We deal with the pituitary and clival lesion, which turned out to be actually a pituitary adenoma, an aggressive pituitary adenoma. And here's the clival area that we've removed this. And now we go anterior, and we're removing the dura anterior. And here is the typical appearance of actually this was not an epidermoid, it turned out to be a dermoid, the typical hair that you see in a dermoid lesion. And here we are removing this from below. The optic chiasm is up here. We do not touch the brain. Here's the anterior cerebral arteries, anterior communicating arteries, and the basal brain. And this patient we were able to do both lesions, and this is the postoperative 6 hours, no CSF leak, length of stay 4 days, home. Here's the postoperative MRI. So there's no question that this is the best approach for that type of combined lesion. So there was a number of advantages with the endoscopic approach: less invasive, no brain retraction. The issue here, you know, are we going to have better outcomes? We're going to need longer follow-up, and are they going to be more cost-effective? We also have to understand that there are disadvantages to this approach. It's a very technically challenging approach. We work through a very small area between the carotid arteries, and we have issues with regard to reconstruction and CSF leak issues. There are important prerequisites, just like open skull-base surgery, for endoscopic skull-base surgery. We need an interdisciplinary team. Here I work with experienced rhinologists, endoscopic surgeons. I believe we need experience with the open approaches so that we can tailor the approach to the patient and not the patient to our approach. Instrumentation, of course, is important, and training is important. Here's our series of now expanded approaches, about 200 patients we have, and you can see the pathologies, very similar pathology that we had with our open skull-base series, and a variety of other pathologies. So let me tell you where I believe the endoscopic approach has replaced or will replace open approaches. And this is in the benign extradural lesions, as you see, encephaloceles and a variety of tumors. And these can be now totally done endoscopically. This is an encephalocele that prior would have required a craniotomy. This is a paranasal osteoma, again, likely a craniotomy or lateral rhinotomy. These tumors can all be removed using an endoscopic approach. This is a cholesterol granuloma of the petrous apex that would have required a craniotomy lateral approach. This we can do now totally through an endoscopic approach, as shown here. And here we are now just at the end, taking off, amputating the encephalocele that we see anterior, and this is the frontal sinus that we can see anteriorly, and this is where the encephalocele came through. You can see the hole in the anterior skull base. We then put a cartilage, and then we repair it with either fascial ladder or nasal septal flap. In fact, any lesion that is between the frontal sinus and clivus, between the optic nerves and at least the orbits and maxillary, these all can be taken out using an endoscopic approach. We no longer need to do a craniotomy for these, and you can see how we can go laterally to the pterygopalatine. Prior to this, we would have used a lateral rhinotomy for this, or craniotomy. Absolutely not necessary. Here we are taking out the tumor. It's done using a bimanual technique with a posterior septal osteotomy, and allows us to remove the tumor in a same way we'd do it from above. And there's a tumor coming out of the nose, and there's a repair. And this is the patient. This patient's in hospital for 2 days. Can go home. This is 4 years later, no evidence of disease recurrence. This shows you our evolution. 2002, patient presented with epistaxis, left nasal thing. This is very classical for an ENT, and used for juvenile angiofibroma. It's a tumor in young men, little tumor. How would we manage that? Well, these are very vascular, so we do preoperative embolization, and the classical technique there was a lateral rhinotomy using a microscope. This is a postoperative. We see we left tumor deep, because it's very difficult with the microscope as you go deeper to see that. We watched this patient. 2007, he had recurrent disease. So what is the best approach? Now we had increasing experience with the endoscopic approach, and you can see basically the removal of this tumor purely through an endoscopic approach, not requiring an external. 3 years later, total, at least no evidence of recurrence. Chordoma. Chordoma is a tumor that is a midline tumor of the clivus. The endoscopic approach really is the best approach for these tumors. Of course, they require adjuvant treatment, as you know, in terms of either proton beam or photon radiation. The advantages are, just as I said, it's a really midline approach for a midline lesion. no retraction of the brain. And here's a typical lesion. You can see a clival chordoma going intradurally, compressing the brainstem. This, I'm not going to show the movie because of time, but you can see after the removal, no CSF leak, proton beam radiation. 5 years later, no evidence of disease recurrence. And this is what you see basically with this approach. Here's another chordoma. This is a view that you would not get from any other approach, surgical approach. This is a basilar artery now. We've removed the tumor. You can see the posterior cerebral arteries and the removal of the tumor. This is post-operative MRI scan that you can see here. Malignant lesions, this is a little controversy in the issue of malignant lesions. Should we do endoscopic? Because the whole concept of en-bloc resection for malignancy that we all know it's the major concept. We have had experience with malignant tumors. Majority is esthesioneuroblastoma. And here's after the removal of this tumor, small tumor. What we do is we remove from below the same way we'd remove the skull base from above. And the key in these malignant tumors to be able to get negative margins. It does not matter that you have to have en bloc, but as long as you get negative margins, then you've done the same approach from below as from above. 6 hours, negative margins, no CSF leak, length of stay in hospital, 4 days. Here's the patient's post-operative MRI scan. Here's another patient. This is a squamous cell carcinoma involving the anterior skull base. You can see we're taking it off. This is the olfactory nerves that you have to take. And after the removal, again, the key is to be able to get negative margins. If at surgery we do not get negative margins, we always prepare for a craniotomy. We'll go from above, but in cancer, as you know, in the end, you have to get negative margins. Of course, they get post-operative radiation therapy. Here's the patient's post-operative MRI scan. So there's no question that the conclusion, at least at this stage, is that in well-selected patients, and this is very critical, that the evidence does support endoscopic resection of sinonasal malignancies. Craniopharyngiomas is a benign tumor, very difficult tumor to access. I believe the endoscopic approach also will become, in the majority of these, with some exceptions, the procedure of choice. There are many approaches for craniopharyngiomas that you can see here. The endoscopic approach is a more straight line approach. You don't have to do any retraction on the brain. And here's a patient who's 70 years old, severe memory deficit, mild endocrine, craniopharyngiomas. The classical approach for this is an open approach. If you ask a number of neurosurgeons here, either terional approach, subfrontal approach, interhemispheric approach. The problem with the open approach is you very limited access. You have to access it through the lamina terminalis, anterior to the optic nerves, between the carotid artery, and these are very, very limited. And despite our best efforts, this is a flare 2 MRI. You see there's always some degree of retraction injury to the brain. And this is a patient's post-operative. You see it was done with residual disease. You can get it all. If we look at the endoscopic approach of a similar lesion, you can see the incredible difference in terms of the exposure that you get. We're removing the bone at the base of the skull through the nose. This is the anterior intercavernous sinus. This is, we've taken the bone off the planum of the anterior skull base. And as we go through, you will see now we come on to the craniopharyngioma. And it's, we're fortunate this is a soft, but you can see at this point, this is the optic nerves. This was caused, craniopharyngioma, as you know, cause optic neuropathy. And here we are bringing the tumor forward. We do not see the brain. We do not touch the brain. And at this point, just careful by microsurgical approach, microsurgical technique. And as we are coming along here, we're taking it off, and this did not go into the third ventricle, so actually we were able to get a total removal of this craniopharyngioma, including sparing the stalk. So here's the tumor after the removal of the craniopharyngioma, and this is basically the pituitary stalk that you see was spared, the pituitary was spared, and no changes in the brain. And in my own experience, you can see here over the last 5 years, 23 patients, 18 I've done an endoscopic approach, 5 open. Finally, this is the last, I'm not sure how many minutes I have, but meningioma. This is a very controversial in neurosurgery, in skull-base surgery. It is really an endoscopic approach appropriate for these tumors. These are intradural tumors, skull-base tumors. And this is a 70-year-old female with this with this meningioma. And this is using an endoscopic approach from below. You can see here, and we're removing basically the base here. And in selected patients, this can be removed easily from below using the same techniques that we use from above. And there's the removal of the tumor. The patient, and it's a repair with a nasal septal flap, 7 hours, 5 days in hospital, no CSF leak, improvement in vision. And there's a post-operative, 4 years later, no evidence of disease recurrence. So, the conclusions basically with regard to is that skull-base surgery can result in improved outcome and functional survival with acceptable morbidity in a selected group of patients with skull-base neoplasm. Open approaches are still very important and necessary in skull-base surgery. However, quality of life and functional status should be very important determinants of decision-making in skull-base surgery. The extended endoscopic approach to skull-base is an established and less invasive alternative to open transcranial procedure. However, and in experienced hands with very, very careful patient selection, the techniques has been shown to be both feasible and safe. However, appropriate training, instrumentation, and an interdisciplinary team approach are important prerequisite for success in these techniques. And of course, we need a larger series of patients with longer follow-up to fully validate the efficacy of this approach. There's no question, however, that the endoscope is a very valuable tool and a very valuable addition to the skull-base surgery and should be in the armamentarium of every skull-base surgeon. So thank you very much. The evolution of skull-base surgery, where are we going? It has to be, and when we go to these always open versus minimally invasive, that's not the key, or at least the issue. It's in the future of skull-base surgery is going to be a combination of open approaches and minimally invasive approaches, and that really is the future of skull-base surgery. So thank you for your attention, and a great invitation. And an invitation to all of you. Adriana knows this city very well. This is Toronto by beautiful Lake Ontario. So an invitation to all of you to visit Canada in the future. Thank you.
Red Lano, Red Latinoamericana de Neurooncología.